everything you need?
Yeah.
Okay.
Hi, good morning, everyone. We will get started here in a moment. We're letting the call build. Just as some housekeeping as we're getting together and starting, you are welcome to submit questions that you might have for Amber during this webinar to the Q&A function, which you'll find at the top of your Teams window. Please use that Q&A function for any questions that you have. We'll be monitoring those and pushing those to Amber for either question or answering those questions, or someone on this call will also be looking at those and responding as we're able to. I believe that questions that aren't answered today may find their way into an FAQ document at a later date. So again, we'll be getting started here at 10 a.m. So please stick with us. We'll be back in a moment. Hi, good morning, all. Just a reminder for those who have just joined us, our cameras and mics are off during this presentation, but if you have a question, you are welcome to use the Q&A function that's at the top of your Teams page. We'll be looking at those questions and responding to those as we move through the presentation. I believe that we're ready to get started, Amber, so if you would, I'll turn it over to Amber Pierce.
Absolutely. I think we may still have a couple more people joining. I know when I looked yesterday, we had about 75-ish, so we should be pretty close. Good morning. I am Amber Pierce. I am the Director of Policy and Training for the Bureau of Disability Services. I'm joined today by Heather Dane, the Chief Program Officer for Bureau of Disability Services. Megan Johnson, who also serves with the Bureau of Disability Services, and Kyle Ingram, who serves as the Director of Policy and Strategic Initiatives for the Division of Disability and Rehabilitative Services. We want to take a minute and warmly welcome you all. The point of our webinar today is to discuss the Bureau of Disability Services practice guidance regarding cardiopulmonary resuscitation, specifically training and individual preferences for life-saving measures within home and community-based services. The guidance clarifies provider expectations and case management responsibilities, as well as following an individual's designated preferences regarding CPR. So just some key points that I want to briefly highlight. As Kyle said, this will be recorded. It'll be posted to the DDRS website once we have completed the webinar. Throughout the presentation, we are going to request that you drop any questions that you may have in the Q&A. So please share all of those. Once we've kind of collected all of those questions, our team is going to work pretty diligently on developing and distributing an FAQ for anything that we aren't able to answer or address today. We just want to make sure that we are able to give the most thorough and reflective answers possible. So Heather and Kyle are both going to assist with monitoring that chat during the presentation. Please do be patient with us. We just want to make sure that we give the most thorough feedback possible, but we will have those answers if we don't have them right now. So something that I do want to also note is that the guidance serves to inform individuals about preferences regarding those advanced directives and that future medical care and treatment planning. All of these designations are legally binding when they are executed by a competent adult aged 18 or older. And these directives can include provisions made by legal guardians or appointed representatives where applicable. However, it is important to note all signed physician orders of scope of treatment, which is also referred to as the post, advanced directives, and do not resuscitate orders or out of hospital do not resuscitate orders are voluntary. They reflect the personal choice of the individual, and individuals have the right to cancel these directives at any time should they choose to do so. In the event of the cancellation, the individual or applicable parties must clearly indicate their request to all relevant parties to ensure proper acknowledgement and implementation. Just another note, this disclaimer is not intended to be perceived as legal advice, and individuals are encouraged to seek professional legal counsel for specific guidance related to personal circumstance. No guidance contained shall be used to subvert or otherwise avoid alignment and compliance with state and federal statutes. So just kind of a quick overview of our agenda. We will be discussing the topic overview, which is that practice guidance that was developed by DDRS and BEADS regarding individual rights and preferences, with designation of life-saving measures or CPR. The guidance was issued February 4th of this year as a companion guide to the previously issued policy titled Advanced Directives. We'll discuss more regarding BEADS as well as our learning outcomes for the webinar and really diving into those individual rights and preferences in relation to CPR and designations. We will also cover content on methods of declaration and the difference between those methods, as well as documentation requirements and validity. And we'll highlight the current expectations and requirements, as well as defining who those providers of home and community-based services are and who this impacts. We do plan to provide that overview of roles and responsibilities for our providers, as well as our case managers in terms of individual rights. Something else to note is that there will be some resources mentioned at the end of the slideshow, just as reference for further information or clarification purposes. So we can dive on in. There we go. Just a short little overview. The Bureau of Disability Services and the Division of Disability and Rehabilitative Services are committed to connecting individuals and their families with resources and supports to live their best life, granting equal access and opportunities in person-centered, inclusive, and collaborative empowerment. So some of the other things that we will kind of highlight are those key terms that we have defined and we have utilized throughout the guidance rationale, and the scope and application of the guidance, just to kind of further clarify. So the Bureau of Disability Services and the Division of Disabilities and Rehabilitative Services really want to focus on that connection and building those support networks for individuals and families. So the mission for DDRS is to support a wide variety of Hoosiers with disabilities to create a vision for the future, using paid and natural supports to build and enhance their personal strengths and assets. All people have the right to live, love, work, play, participate, and pursue their dreams within their community. We really prioritize the core values of dignity, strengths-based communication, informed choice, supported decision making, the right to self-direction, the right to self-advocacy, and holistic supports. And through that, we have developed the guiding principles that really help to chart our course. So those guiding principles are facilitating opportunities for our friends, family, members, and fellow Hoosiers with disabilities to have full lives in the community, empowering our friends, family, members, and fellow Hoosiers with disabilities to be the defining voice in identifying their goals and their good life. And partnering with our friends, our family members, and fellow Hoosiers with disabilities to ensure Hoosier communities include everyone. Something else that I want to really focus on is that lifespan empowerment and what that means for us. Providing continuous support and lifelong commitment for citizens in the disability and rehabilitative support arena in the state of Indiana today, as well as in the future, just to ensure that alignment and that continued support and care. Okay, so just to touch on some of these key terms that we did pull out into the guidance. Case manager. So case manager means to reference 455 IAC 2-4-10 and 460 IAC 6-3-9. The personnel assigned to provide case management services and inclusive of the term care manager as well. Another term we have is designated preference or designation. This means a written declaration of an individual's preferences for life-saving measures, which takes the form of an out-of-hospital do not resuscitate declaration, or physician's order of scope and treatment, as well as an advanced directives form. However, the advanced directives form must include a validated and signed post or DNR form with that declaration. DNR means the out of hospital do not resuscitate declaration established under IC 16365. We utilize individual to mean a person who has been determined eligible or is currently receiving BDS operated home and community-based services waiver services in accordance with 455 IAC 2-4-20 or 460 IAC 13-3-10. Life-saving measures are defined as interventions intended to prevent death and resuscitate or stabilize an individual, but are not limited to cardiopulmonary resuscitation, first aid, abdominal thrusts to dislodge any airway obstruction, and medication administration. Post means the physician order of scope of treatment under IC 16366. And then we define provider as a person or entity approved by BDS to provide the individual with agreed upon services as defined in 460 IAC 6. To kind of further break this down, service plans have a couple of different meanings. So for an individual receiving FSW services or CIH waiver services, this is going to be the person-centered individualized support plan defined in 460 IAC 6-3-32. For individuals receiving services under health and wellness or traumatic brain injury waiver. This is going to be referred to as the person-centered support plan defined in 455 IAC 1-5-2, Section 8. It also refers to the term care plan, so those are synonymous. So a little bit about our practice rationale. The guidance document was to provide clarification to providers on existing requirements regarding cardiopulmonary resuscitation training of staff and expectations for respecting individuals' choice and the receipt of life-saving measures. Our scope is going to kind of further delineate. So the identified scope and application of the guidance are really to kind of tether out who serves as those providers, what that looks like and means for home and community-based services through the waiver, including those that are employed with approved entities or agencies and our case management providers. Our learning outcomes are pretty straightforward. So hopefully by the end of this webinar, you can understand the practice guidance and requirements surrounding CPR training, identify individual rights and preferences regarding life-saving measures, understand declaration methods. These do include the OHDNR form, the post form, as well as a little snippet on the advanced directives with accompanying documentation. And then recognizing the roles and responsibilities of home and community-based services providers and case managers in respecting and documenting individual choices. So let's kind of jump into individual rights and preferences. And I do apologize. I know some of these slides could be a little bit small and hard to read. You should be able to select the pop-out feature to see a little bit better. I apologize if you cannot. So kind of going back to individual rights and preferences, any individual served under the home and community-based services waiver are encouraged to exercise their rights to exact personal preferences regarding advanced directives planning, do not resuscitate declarations, or post forms. The individual or their legal guardian or representative, when applicable, have the right to designate their individual preferences regarding life-saving measures in terms of CPR in one of a few legally recognized methods. So all declarations or designations must be voluntary of the individual's own wishes. The individual has the right and ability at any point to amend or revoke these designations at any time. The requirements and the steps for this process are outlined within the practice guidance document for further reference, but we will also kind of further clarify through the presentation. It is the expectation that providers and case managers will respect and recognize the elections made by these individuals, ensuring that they're properly documented and communicated to all relevant parties if there are any changes or any updates. Again, the disclaimer that this is not intended as legal advice, and individuals are encouraged to seek professional legal counsel for specific guidance related to their personal circumstance. No guidance contained within shall be used to subvert or otherwise avoid alignment and compliance with state and federal statutes. So just kind of looking at some of the declaration method pieces. I know we talked about each individual having the right to exact their preferences, but let's talk a little more about what these declaration methods are. So the methods that are set forth to kind of take those steps of documenting those decisions and choices can be utilized as a notarized out of hospital do not resuscitate declaration form completed by a competent individual over aged 18. However, this must be signed by a physician and it has to be legally notarized. Another option is our assigned physician order of scope and treatment, which is also the post form, listed under SF 55317. This form is completed with the primary care physician or noted medical doctor or specialist and the individual or their legal guardian if applicable. And the last option that we have is notice of advance directives. However, as I previously noted, this is required to include a notarized copy of a out of hospital do not resuscitate order, SF 495559, or a signed physician order for scope of treatment. That's how we are able to know that these are validated. It should be noted that these two forms can be identified and linked. Those can be found on the state website, as well as IDOH's website. But it should be noted as well that these forms are required for adjudication of advance directives or future medical care and treatment planning. If the individual or legal guardian have any additional items, they can also submit that, but these forms are required. Also note that if there is a legal representative or appointed guardian, they must be a part of this decision-making process with the individual. As a reminder, we are recording this for future guidance, and it will be posted to our website, but please do feel free to drop any questions that you may have in the Q&A. Also, please know, as we talk about these declaration methods, each member of the individual support team really does serve a role in this through the communication, implementation, and just discussion, and the best ways to support and follow those wishes. So we can start with the out of hospital do not resuscitate declaration form. It is a legally recognized state form completed by an individual to express their preferences regarding CPR resuscitation administered and other life-prolonging measures. The declaration and intent to execute an OH-DNR form must be made voluntarily in writing. The written communication piece is imperative for validation purposes. The form should be signed by the individual and the presence of at least 2 competent witnesses. Following the signatures, the attending physician will verify that the individual qualified and issue that do not resuscitate order. The declaration should be shared with the individual medical care provider, any specialists, providers of home and community-based services, and the individual support team. The form should travel with the individual to ensure adherence and observation of medical care and treatment. The DNR declaration form is voluntary, meaning that it can absolutely be canceled at any point at the individual's discretion. However, in the event of a cancellation, the individual or other applicable parties must clearly indicate their request to all relevant parties to ensure proper acknowledgement and implementation. Other references that could be for a little more assistance or guidance is IC 16-36-512, which discusses issuance of a DNR. IC 16-36-5-12 and 5-13, transfer of patient to another physician. And those both just outline some of the processes of ensuring that communication piece continues and is shared. And then here is an example of what the DNR form looks like. As I noted, it is SF 49, 55, 59. And again, just to reiterate, this is completely voluntary. This must be voluntary of the individual's own choosing and can be canceled at any point. Another option that we have is the physician order of scope of treatment. So this form is also legally recognized as a state form, and once completed, is legally binding. However, it does have to be completed with the individual's medical professional. This can be kind of inclusive because it also states the individual's medical conditions and preferences regarding medical intervention, medical treatment, resuscitation, and lifelong prolonging efforts, nutrition, and hydration. An individual that seeks completion of a post form shall meet with their healthcare professional to discuss their health conditions, treatment, and care options, as well as really figuring out what their wishes are and documenting that. If the individual does have that legal representative or appointed medical proxy, that individual should also be present and included in that facilitation whenever applicable. The individual's healthcare professional shall complete the post form for review by the individual and, when applicable, their representative or proxy. However, to note, the validation of the post form, both individual and healthcare professional are required to sign this form. If the legal representative or guardian proxy is a part of this process, that should also have their signature for validation reasons. The form should absolutely be shared once signed and completed with the individual's medical care providers, medical specialists, providers of home and community-based services, much like the DNR form. Much like the DNR form, this will also follow the individual to ensure adherence and observation of their choices and preferences in that designation. The post form is also a voluntary declaration. It can be canceled at any point within the individual's discretion at any reason, anytime. In the event that the form is canceled or they elect to revoke that designation, the individual or other applicable parties must clearly indicate their request to all relevant parties to ensure that proper acknowledgement and implementation. All right. This one's a little bit more squished because it's a two-page form, but this is also something that you can find on the Indiana website. I have the, sorry, I thought I had the link. Heather, would you be able to drop the, if you haven't already?
Amber, it's already in there. It's
Thank you. I can't see the chat, so I apologize for that. But Heather did drop that into the chat, so you can find those forms as well as other resources and information on the IDOH website. There are some other fact sheets and information to just kind of help guide and give people a little more information about the process. So let's talk a little bit about documenting designations, preferences regarding life-saving measures. As provided for in state law, an individual may designate their preferences for life-saving measures through one of the following methods. A DNR declaration that follows the format of State Form SF 495559 and completed in accordance with IC 16365, a physician order for scope of treatment or post form document on State Form SF 55317 and completed in accordance with 16 IC 16366 or an advance directive that includes a valid DNR or post form. A valid DNR may be executed on the state form or in a separate document that uses the same wording and format as the state form. Just another disclaimer, this is not intended as legal advice, and individuals are encouraged to seek professional legal counsel for specific guidance related to personal circumstance and choice. No guidance contained shall be used to subvert or otherwise avoid alignment and compliance with state and federal statutes. And again, these forms are available and accessible on the state website as well as IDOH. I believe the state website is forms.in.gov, and you would just search the form title. Oh, shenanigans. Sorry, guys. Okay, so let's talk a little bit about validity. In transparency, all of these declarations are completely voluntary. They must be made in writing. They must be signed by the individual or other person in the declarant's presence and at the declarant's express directive. They must be dated and they must have appropriate supporting documentation, meaning that the doctor has signed off after verifying what they have put in the form for either the DNR or the post form with those choices. I will note that the post form also requires that consultation with the doctor for that validity piece. But these forms, like I said, can be found on the IDOH website or the forms.in.gov website. Revocation of designation preferences for life-saving measures. When an individual cancels or amends that declaration or designation on life-saving measures, the individual or their legal representative must provide all members of the individual support team with written documentation of changes to their designation so that the individual's current designation preference can be documented within the service plan as an addendum. The individual may provide this written documentation in physical or electronic form and may request assistance from the case manager to distribute the current designation preference to other members of the IST. Codes for reference would be IC 1636-5-18, which is the revocation or cancellation of DNR preference. 1636 4-12 is going to be revocation of a living declaration or life belonging procedures. So those advanced directives. And then 1636-732 is going to reference revocation of the post form. And what those steps are, what that looks like, it's just the specific code citation. Something I again want to stress though, like all of these designations are completely voluntary. They are at the request of the individual. So another disclaimer that I want to throw in here, no provider or case manager is required or permitted to give any legal guidance of any sort. So let's talk a little bit about who providers are. Providers are accredited professional organizations that have gone through the vetting process for approval to provide not specifically just beads, but also Medicaid, waiver, home and community-based services. This also includes the employees or agents of a provider who work with those individuals directly, regardless of their title or position within the company, and anyone who provides that direct care to an individual in any capacity. So just kind of another little snippet about what those expectations look like for providers. We very much so want to stress the importance on any provider of home and community-based services, especially in any capacity, and its personnel are expected to render cardiopulmonary resuscitation to any individual receiving services under the home and community-based waiver services absent a valid DNR or post form. With saying that, the expectation is that all agents of the organization or employees who provide care or work directly with that individual, regardless of that role or position, are expected to and required to have a valid CPR and first aid certificate from an accredited source. So the current accredited sources are American Red Cross, American Heart Association, National Safety Council, American Health and Safety Institute, or Emergency Care and Safety Institute. This does include demonstration of hand-on skills practice and observation. Current provider requirements. So for personnel requirements, home and community-based providers must ensure compliance with CPR training requirements under I 460 IAC 6-15-2 and 455 IAC 2-14-1. All personnel working with individuals must have up-to-date CPR certification from a recognized entity. This requirement applies to direct care personnel regardless of job or title, or anyone who works one-on-one with an individual. Providers must maintain records of these trainings to ensure that staff are prepared to render CPR when necessary to any individual in need of resuscitation, unless that individual has a valid designation indicating their preference that CPR not be rendered as a life-saving measurement, and it is documented in their service plan. The provider is responsible for informing personnel who work with those individuals of that designation and preference, especially if CPR is not something they wish to be rendered, and making sure that that's communicated and documented very clearly for anyone who does provide that direct care. Providers are also expected to have policies in place to ensure that staff are aware of that individual's designation, and that it should be documented within whatever file or binder that they have for service records. Another thing to note is that it is also an expectation that anyone who works with that individual has current person-centered training that reflects really the diagnosis, any treatment or scope of care for the individual, medications, any kind of behavioral support plans, things like that. But also, most specifically, it highlights the respect for an individual regarding their preferences, as well as any other like choices regarding designation for life-saving measures. And the expectation is that through that training, DSPs would respect and follow those wishes. They should also be trained to recognize and respond to medical emergencies appropriately. Things that are noted in high-risk plans and things of that nature should absolutely be something that individuals that work in the homes or in the community with those individuals should be aware and prepared for. And then just understanding, moreover, like how to communicate and document any changes that individual may have in those designated preferences. Providers should also have policies and processes in place to ensure that the personnel working with the individuals are timely informed of an individual's designated preferences for life-saving measures. Once an individual would elect to observe advanced directives, the provider of home and community services will be expected to ensure completion of current person-centered training with all personnel and staff who provide support to the individual, denoting advanced directives planning or CPR declaration designation. The accredited professional organization is responsible for maintaining documentation of each of the above items within the personnel file. Each employee or agent who works with an individual is required to, again, maintain current active certificates and certification of cardiopulmonary resuscitation, as well as recent current person-centered competency training. And all of those verified training records should be held within that personnel file for that individual. Please note that another thing to consider is that should BEADS or a designee or a case manager need to request those personnel trainings or files, they are able to do so, and it is the expectation that that information would be shared. This can be done electronically or physical copy. It's again that expectation that any and all providers of home and community-based services in any capacity are expected to render cardiopulmonary resuscitation if that individual does not have a valid DNR, post, or advanced directives form. And this just kind of reiterates a little bit more about the CPR training and compliance. So in alignment with 455 IAC 2-14-1 and 460 IAC 615-2, those personnel files are required to maintain up-to-date CPR as well as verification for training sessions. Providers must maintain those records at all times. And they should have policies in place regarding the requirements for any kind of recertification or documentation, and any kind of training requirements around any kind of updates on designations or personal preferences, diagnoses, treatment or care. But once that individual elects to observe those advanced directives, it is the expectation that providers will complete current person-centered training to ensure that everybody does have the same information and that they are on the same page. And again, this is relative to any individual who works one-on-one with someone receiving those services and supports. Just another quick reminder, at any point, those files can be requested if needed, but also no provider or case manager is required or permitted to give legal advice or guidance. Just to kind of quickly overview those accredited CPR entities in accordance with 460 IAC 6.1-11-21. So while you must be trained to administer this, those certifications last every 2 years for recertification, and the approved entities are the American Red Cross, the American Heart Association, National Safety Council, American Health and Safety Institute, and Emergency Care and Safety Institute. I do just want to again note that other items should really be documented, but it is absolutely required that all providers have hands-on practice and observation training component to their CPR certifications. So let's kind of go over some of the case management responsibilities. Our case managers play a key role in facilitating discussions about life-saving preferences and ensuring proper documentation. Some of their responsibilities include annual discussions with the individual and their support teams about CPR and life-saving measures, organizing meetings if an individual is diagnosed with terminal illness to discuss future medical care, assisting individuals in executing a healthcare power of attorney if desired, or referring them to resources in the community. Again, not giving legal advice. Documenting all preferences in the individual service plan and ensuring proper distribution of the documents to all team members. Updating records and informing the individual's IST when an individual revokes or amends their preferences. So just kind of to delve a little bit deeper. In facilitating those conversations, they should occur at minimum annually during the annual service plan meeting, and this should be documented within the service plan as an addendum. If the individual gives notice of a terminal illness, the case manager will facilitate an IST meeting with the parties to discuss that future medical care and treatment planning, including an individual's desire to designate preferences for those measures upon that notification. Instead of maybe waiting until that annual, like doing that upon that notification, because it is a critical juncture and it's a change in status. Should an individual express their desire to execute a healthcare power of attorney, the case manager can and should facilitate an IST meeting to discuss the need for legal consultation services, just to keep everybody on the same page and make sure everybody's looped in with the same information. Another time that an IST should be held is if an individual revokes or amends their designation surrounding end-of-life planning, cardiopulmonary resuscitation, or treatment and planning. The case manager will ensure that there is a meeting to discuss all of those designations, preferences, any changes, and just document and update that. So again, everybody has that open communication across the board on the same page. Okay, so our case managers also have a lot of responsibility with regards to documenting those preferences. So upon receipt of an individual's designated preference for life-saving measures or CPR, the case manager is responsible for documenting or reviewing all designations, including necessary documentations, forms, and appropriate signatures for validity. Once they've taken the steps to ensure the validity, they then need to add a case note, kind of stating this is discussion, team meeting, this is the documentation received. Adding that case note as well as updating those preferences with the service plan as an addendum, just to make sure that it is kind of transparent across the board. Notification should be sent out to any IST members in that event. And then the validated document shall be added to the BEADS portal under the document library for future reference if needed. And we'll talk about this in the next slide, if that revocation or cancellation of those decisions are made, that should also be documented through a case note and documented in that library. So case management role in the revoking or amending. In the event that an individual cancels or amends life-saving measures or CPR designations, the individual or their legal representative, if applicable, must provide all members of the IST with written documentation of these changes to their designation so that the individual's current designated preferences can be documented within the service plan, as well as provided to members of the IST. This can be done via physical or electronic format, but it must be a written documentation. And they can request assistance from the case manager to distribute that to the current IST members and share that information across the board. Okay, I got through this a little quicker than I anticipated. So just a couple reminders. The presentation was recorded. It will be posted to the DDRS Speeds website for future reference. Also, you should, once we've kind of wrapped up, you should get an email link of the recording sent to you through Teams. Throughout the presentation, if there were any questions, we have collected those. We will work on developing that FAQ. Thank you again to Heather and Kyle for assisting with monitoring that chat. If there, okay, so another little quick catch. If there is no DNR, do CPR, and if there is no post, do the most. Just a nice little slogan, or a couple of them, to remember that if we do not have those valid designations, we need to provide that resuscitation and life-saving measures. And then our resources and references, these are just some of the IC codes that were cited. The IDOH website. Something else that I did want to tie in, through our innovation pilot projects, Stonebelt ARC is a initiative that is working towards end-of-life planning and choices for individuals, and really like looking at it from a spiritual approach and talking them through it. You can find that, and I will make sure that that web link gets dropped in the chat. But it is kind of cool. It walks people through the process, gives them a little bit more information about it. It does have a guide that they fill out and complete, and provides kind of a guidance, and it gives them a voice to be able to say, you know, I've talked it over with my supports. This is kind of where I'm leaning, and these are my thoughts. And it gives them an opportunity to document that. So that is something really, really interesting that can be checked out. It can be used as a reference guide or a resource to any of our clients and individuals. I do see a comment in the chat. And it's, will we be asking all individuals, guardians about this, including minors? I believe, yes, we will, but please let me clarify this information, and I will gladly share that in an FAQ. That way it's kind of the same answer across the board. I just don't want to give a definitive answer until I have verified.
Amber, let me jump in here for just a minute on this question. I think the important part of this question is to remember that if a child has a health condition where the parent may feel it's necessary to put in advance directives or a post, you know, those are important conversations to be having with those families. So sometimes end of life conversations aren't dictated by a person's age, but by the health conditions that they are currently facing. So yes, if it is appropriate to have that conversation based upon, you know, what that child's conditions are and what those families' wishes are, then absolutely you should be having those conversations.
Thank you for that, Heather, because that's kind of where I was leaning, but I wanted to clarify before I gave a definitive answer on that. And then just to kind of reiterate, thank you again for giving us your time and learning and just kind of having questions. Please feel free to continue to drop those questions, but also note that if you need that assistance or that guidance in like going forward, if you email beads.help@fssa.in.gov, those questions can kind of filter in, and we can incorporate them within the FAQ that we will be working on developing, with that guidance and the information regarding further clarification.
Amber, it's Heather again. Sorry to keep popping in. But
No,
there
you're
is
fine.
another question that I would like to address. So the question is around how do you suggest having this conversation with an emancipated adult who has no family and has limited understanding of the topic. So I think when we talk about our supports and services, with individuals with disabilities, we should always be including them in the conversation. It is their life, and this is an important part of that conversation. And so I think, you know the individuals the best, and you should be having those conversations to the extent and the ability that they can. And so putting it, it doesn't have to be so technical. The conversation doesn't have to be so technical, but really making sure that we are talking to the individual about what it is that they want for their life, and in some of these circumstances for the end of their life. And so it's just as with any service or support that we provide, you should be having these conversations in a way that the person is able to understand and to respond and to provide their feedback.
And Heather, I do appreciate that because I can't see, like, it's not updating the chat for me for the Q&A, so I can't actually see as the questions are coming in. I'm not sure if that's a Teams glitch or if that's just my Teams not working.
Yeah, I think it's just a little glitch within the within the platform. So we apologize. We are using a different type of platform for this presentation, and so the Q&A is not as user-friendly for us as moderators as it has been in the past with some of this. So there is another question around clarification about what exactly at annual meetings are case managers expected to obtain from individuals and guardians. So are we to share the documents for the DNR post and encourage them to have medical professionals complete it if they feel it's appropriate? If they do not wish to complete these forms, do we note that in the PCISP? So yeah, absolutely. We're not saying everyone has to have a DNR or a post on file. What you should be having are those conversations to ensure that their teams are aware of what those wishes are, and that if that individual or guardian has documentation to support those wishes, we want to ensure that those are documented appropriately, that they're within their document library. Okay, so I think that is all of the questions. Those have been great questions. And Amber, thank you so much for doing a wonderful job reviewing all of this information. So as she stated, the recording will be available to you, but we will also post it on the website. And I would encourage you, as you work through these conversations and, have this information with individuals and families, and share this information with individuals and families, please know we are available. You can always email BEADS Help, so bds.help@fssa.in.gov, and we'd be happy to address any of those questions that you have as they arise. Amber, I'll hand it back over to you to close us out.
Thank you. Thank you. So I appreciate your time. First and foremost, I know it's kind of hard to shift some stuff around, but we do appreciate that you guys took the time to join us. I did drop the link for the Innovation Pilots Project website, specifically in regards to Stonebelt, just because it does talk about some of the end-of-life planning and like spiritual connection and community, as well as some outreach and engagement. I did want to make sure that you guys had that resource. Please continue, like Heather said, any questions that you may have, send them to help.beads at fssa.in.gov. We will work to answer diligently and as thoroughly as possible. You will receive like I said, the email of the recording once we stop recording. But also this will be submitted to the website and posted under webinars. But thank you all so much for your time and your consideration and learning with us. You get a couple minutes of your day back, and we just appreciate you. So thank you all so much.